Hi, everybody. This is the International Academy for Clinical Hematology around the globe and across the hematology field. A very warm welcome to all of you to this webinar dedicated to CAR T cells in acute myeloid leukemia. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it is my great pleasure and honor to introduce our speaker today, Dr. Sébastien Anguille from Belgium. Dr. Anguille is a clinical hematologist. He is also head of the Division of Hematology at the University of Antwerp. And his main focus is AML, especially immunotherapy of hematological diseases, including, of course, not only acute leukemias, but also lymphomas and myelomas. And as you all know, I think in the last 10 years or so, CAR T cells have proved to be a major breakthrough in the field of hematology, especially in lymphoid malignancies. And we have now clearly consolidated results in acute lymphoblastic leukemia, in non-Hodgkin lymphoma, with a very high likelihood of cure in a significant proportion of patients over the long term. We do have very exciting results in multiple myeloma. However, the field has been a lot struggling with CAR T cells when it comes to acute myeloid leukemia. We've seen already a lot of success in autoimmune diseases, especially since the recent publication in the New England Journal of Medicine. But still, AML remains a sort of very hard to treat when it comes to CAR T cells. However, I do believe the situation is not completely hopeless, and there are new techniques and new methods on how to overcome the obstacles and barriers in this field. And this is why we thought to invite Dr. Anguille, who has been focused on this topic now for many years, and he will share with you some of the most recent data and advances in this field, but also some of the future perspectives, which are going definitely to significantly impact the outcome of patients with myeloid malignancies. So, Sébastien, thank you for joining us, and please don't forget that this is a live interactive webinar, so we will have a few minutes for Q&A at the end of the webinar, so please don't hesitate to send your questions, your comments, or whatever suggestions you would like to share with our distinguished speaker. The floor is yours.
Thank you, Professor Moti. I'm going to share my screen. So thank you also to the International Academy for Clinical Hematology for inviting me to give this webinar on CAR T cell therapy in acute myeloid leukemia. As we all know, the prognosis of AML is quite dismal. 5 years after the diagnosis, only 30% of patients are still alive. And this is even with current treatments. As we all know, the treatment of AML has not changed much until recently. We are still using the same intensive chemotherapy drugs as they were introduced now more than 50 years ago in the early 70s. So we are still using the backbone of cytarabine and anthracycline as intensive chemotherapy treatment for AML patients. Now, more than 20 years ago, gemtuzumab ozogamicin, which is an antibody-drug conjugate targeting CD33, was approved by the FDA, but it was later withdrawn from the market and then reintroduced a few years ago, or already a couple of years ago. A major event was the approval of the hypomethylating agents, such as decitabine and azacitidine, And more recently, we have witnessed the advent of oral drugs, such as venetoclax, which is a BCL2 inhibitor, and targeted drugs such as FLT3 inhibitors, gilteritinib, midostaurin. So the therapeutic landscape of AML has changed, not so much as compared to other hematological malignancies, but at least there are some introductions of new drugs. What about CAR T-cell immunotherapy or CAR T-cell therapy? As we all know, CAR T-cell therapy involves collecting T cells from a patient through apheresis, genetically modifying these cells, usually by a lentivirus or retrovirus with a chimeric antigen receptor or CAR, expanding these cells, and the expanded CAR-modified T cells are then re-administered to the patient, usually after lymphodepleting chemotherapy. In vivo, in the patients, these CAR T cells will recognize certain antigens expressed on the tumor cell surface. So the outer part of the CAR, depicted here in red, is actually the part that is usually derived from an antibody and that recognizes the target antigen expressed on the tumor cell surface. Upon binding of the CAR to the antigen, the CAR will trigger T cell activation through the intracellular T cell signaling domains of the CAR construct. As Professor Moti mentioned, CAR T-cell therapy has revolutionized the treatment of certain hematological malignancies, especially the lymphoid malignancies such as B-cell acute lymphoblastic leukemia, aggressive non-Hodgkin lymphoma, and more recently also multiple myeloma, where BCMA-targeted CAR T-cell therapies have yielded exciting results. What about CAR T-cell therapy for AML? Well, for AML, as you can see here, there are no approved products yet, and CAR T-cell therapies have been tested, but only in a limited number of patients and in early phase clinical trials, usually phase 1 clinical trials only. To date, whilst preparing this presentation, I performed a PubMed search, and as you can see here, by entering the two keywords, CAR-T and AML, this yielded only 399 results. So if you have a look at the graph in the upper left corner, in the past 10 years, there has been not so much research on CAR T-cell therapy in AML. Only the last 4 years, you see an expansion of the number of publications in this field of research. So still, overall, this is currently a small research field. Nevertheless, clinical trials have been performed, so it might be interesting to have a look at these results, the data gained through these early phase clinical trials that have been performed. Most CAR T-cell therapy trials in AML so far have targeted CD33, CD123, and CLR1 or CLEC12A. Other targets that have already been explored in the clinic are CD38, which is also expressed, for example, in multiple myeloma, and a target of daratumumab. We also have NKG2D ligands, which are abundantly expressed on AML cells, the Lewis Y antigen, CD19, which is normally expressed on B cells, expressed in B-ALL, but can also be expressed in a limited number of patients in AML, and CD7, which is a T-cell antigen, can be expressed in T-ALL, for example, also in certain types of lymphoma, but also in AML. For these targets, we already have clinical trial data. Professor Moti was alluding that the therapeutic efficacy of CAR T-cell therapy in AML, in relapsed refractory AML, is rather limited. But when we have a look at a recent meta-analysis that included 57 patients with relapsed refractory AML, a pooled CR/CRI rate of 48% was obtained, meaning that about half of the patients can achieve a complete remission with CAR T-cell therapy. The objective response rate was 57%. So this indicates that although the data are from phase 1 clinical trials, CAR T-cell therapy can be efficacious in AML in a substantial number of patients. Almost half of the patients achieve a CR or CRi. And this is an overview of all trials that have been performed. As you can see here, those have targeted most commonly CLL1, CD33, and CD123, and the other targets I've mentioned already before, CD38, NKG2D ligands, Lewis Y antigen, CD19, and CD7. There are 4 trials that I've highlighted here in yellow that have remarkably high CR rates. More than 70% of the patients responded, achieved a CR or CRi. And I think it's quite relevant or quite useful to have a deeper look into these trials. The first trial, published 2 years ago in leukemia, was performed in pediatric AML. 8 children were treated with a CLL1 targeted CAR T-cell therapeutic product, and the CR/CRi rate was 75%. But due to the expression pattern of CLL1 on normal blood cells, especially granulocytes, all patients developed severe neutropenia, long-lasting neutropenia. Some patients developed agranulocytosis, and this necessitated actually to go for an allogeneic hematopoietic stem cell transplantation quite rapidly after CAR T-cell treatment. So most of these children were treated with allo-HSCT after CAR T-cell treatment. Similar results were obtained in an adult population, also published 2 years ago in Journal of Hematology and Oncology. So 10 adult patients were treated with a CLL1 targeted CAR T-cell therapeutic product, and the CR/CRi rate was 70%. But all patients developed severe pancytopenia, and in most of these patients, like in the pediatric population, allo-HSCT was performed. So you can actually conclude that CAR T-cell therapy was used in these trials as a bridge to transplant, to bring the patient into remission and then to go for a transplant as consolidation. So it makes it really difficult from these trials to draw firm conclusions about the durability of the responses and to draw conclusions about the standalone efficacy of CAR T-cell therapy in AML. A Chinese group, these data were presented at EHA 4 years ago, examined dual targeting CLL1 and CD33 in adult patients with relapse refractory AML, and they also achieved a high CR/CRi rate with about 8 in 10 patients that responded. Responses occurred rapidly. Most patients entered into CR already after 1 month. But hematotoxicity was also considerable, and hence most of these patients also proceeded to allo-HSCT, making it difficult to draw conclusions about the long-term clinical activity of this dual antigen targeted CAR T-cell therapeutic product. One group investigated a CD38 targeted CAR T-cell therapeutic product, not before HSCT, but after allogeneic HSCT. So it was used in patients that relapsed or were refractory after allogeneic hematopoietic stem cell transplantation. Also in this population, the CR/CRi rate was quite high, 70% in the population that was presented at EBMT in 2023. But as you can see here, after 6 months, already 50% of the patients had relapsed. And this gives some indications about the durability of responses that we can see with CAR T-cell therapy as a standalone treatment in AML. What about the toxicities? And what about the typical CAR T-cell related toxicities, including cytokine release syndrome, CRS, and immune effector cell associated neurotoxicity syndrome, ICANS? A recently published meta-analysis actually indicated that the CRS rate is about 67%, and the rate of ICANS is 10%. So to summarize, for the toxicities that are typically associated with CAR T-cell treatment, we see that 2 out of 3 patients experience CRS. And CRS is also linked with clinical activity. So the highest rates of CRS were observed in the clinical trials where high CR/CRI rates were reported. ICANS is not so common. It occurs in 1 out of 10 patients, and you see a difference here with, for example, Yescarta, which is used in non-Hodgkin lymphomas, where about 5 out of 10 patients will experience neurotoxicity. Hematotoxicity is considerable, and that is, of course, due to the fact that most of the antigens are also expressed on normal hematopoietic stem cells, progenitor cells, or differentiated blood cells, and this hematotoxicity occurs in nearly all patients, especially with the antigens that we are currently targeting, such as CLL1, which is expressed on neutrophils. This can lead to severe complications, for example, agranulocytosis, which can be potentially lethal. And this actually limits the applicability of CAR T-cell therapy in AML, meaning that we can only use it, I think, personally, when targeting these antigens as a bridge to transplant. So we need an allogeneic hematopoietic stem cell transplant afterwards to rescue these patients. So to summarize, there is some experience with CAR T-cell therapy in AML. It is limited. There are different targets. CLL1, CD33, and CD123 are the most commonly explored targets. We only have early phase clinical trial results. Less than 100 patients have been treated so far. The efficacy is limited. Although the CR/CRI rate is 50%, response durability is questionable. And especially when you compare this with the currently approved CD19 and BCMA targeting CAR T-cell therapies for B-cell malignancies and myeloma. But nevertheless, is the glass half full or half empty? I think it's half full. These response rates are quite high, especially in this population of patients in a relapse refractory setting where the therapeutic need is high and where therapeutic options are limited. Toxicity is considerable. CRS and ICANS are within the expected range. It is what we can expect from CAR T-cell therapies, but the hematotoxicity is the main problem and the main limiting toxicity. And this actually brings us to the second part of this presentation, to the $1 million question. How can we proceed? How can we now unlock this full therapeutic potential of CAR T-cell therapy in AML? We know that it has the potential to work, but how can we improve it? And I have some suggestions. One of these suggestions is to find better antigens. And the ideal antigen or the ideal target antigen in AML is expressed in most AML patients or virtually all AML patients, and within a given patient also homogeneously expressed among all AML cells. It should not only be expressed on bulk AML cells, the blast population, but also on the leukemic stem cell compartment. These leukemic stem cells are responsible for relapse and for maintaining the disease. And of course, the target antigen has no expression or negligible expression on normal hematopoietic stem cells, progenitor cells, or more differentiated blood cells or non-hematopoietic tissue. The question is, can we find such antigen? For CD33, CD123, and CLL1, the currently explored targets, we know that they are broadly expressed among patients. Also within a given patient, they are quite homogeneously expressed. They are also expressed on leukemic stem cells, but unfortunately, especially for CD33 and CD123, there is also expression on the normal hematopoietic stem cells and hematopoietic progenitors. And for CLL1, there is notable expression on more mature blood cells, such as neutrophilic granulocytes. And this actually, as already discussed before, can lead to severe neutropenia and agranulocytosis. So these antigens are expressed in AML patients and homogeneously within a given patient. They are found not only on AML cells, but also in LSCs. But the problem with these antigens is the expression on normal cells, blood cells. What about the other targets that have already explored in clinical trials? Well, there you can already appreciate from this table, we see that the expression among AML patients is not so high. For example, for CD7, it's not a typical AML antigen. It's a T-cell antigen, and it can be expressed in 1 out of 3 AML patients. The same applies to the other antigens listed here. And although there can be expression on AML cells, the expression in the leukemic stem cell compartment is not entirely clear, but the advantage is that there is also no expression on normal hematopoietic stem cells or progenitor cells, and the expression on the more mature blood cells is actually acceptable. CD38, for example, is expressed on plasma cells, as we know, CD19 on B cells, and CD7 on T cells, but this can be circumvented. But as you can see here, these targets are also not the ideal candidates. In 2017, Perna et al. Identified 5 new antigens that actually fulfilled the criteria of the ideal target antigen in AML. The 5 targets are listed here, and as you can appreciate from the table, these antigens are also found on AML cells and LSCs. They have no or limited expression on normal hematopoietic stem cells or progenitor cells, and their expression on mature blood cells is also negligible. The question is, are these antigens broadly expressed among the heterogeneous AML population? That is something that we need to delve into, but these are quite interesting targets, and especially, for example, CD70, for a certain subgroup of patients, it can be a very good target. Very recently, a novel target that is also expressed in solid cancers, 5T4, was identified. And this is, for me personally, an interesting target because it's expressed in about half of AML patients. It is not only expressed on AML cells, but also expressed on the leukemic stem cells. And in vitro research has shown that these 5T4 CAR T cells do not target normal hematopoietic stem cells. So this might also be an antigen that fulfills the criteria of the ideal target antigen in AML. However, the quest for antigens or the search for the ideal target antigen is on. I performed a literature search on PubMed, and to all these antigens listed here, CAR T-cell therapeutic products have been developed, not tested into clinical trials, but in vitro research and in vivo research in mice have been performed with CAR T-cells targeting these different antigens listed here. So a lot of antigenic targets are being identified, new targets, and hopefully we will find or we will be able to identify more AML leukemic stem cell directed antigens and antigens with limited or no expression on the normal hematopoietic stem cells or blood cells. It is also important to note that AML cells, or the majority of the antigens expressed by AML cells, are intracellular antigens. These are antigens that are processed internally and presented as epitopes, small peptides, in the context of MHC molecules. Of course, these antigen MHC complexes cannot be recognized by conventional CARs. And this is why we need to develop T-cell receptor mimic CARs if we want to target these intracellular antigens. And such CARs have also been developed to several intracellular antigens expressed on the AML cell surface, including nucleophosphine 1, PR1, PRAME, SSX2, and Willem's tumor 1. So a lot of targets, and the search is on, We are identifying new antigens at rapid pace. There's an intensive search going on, and I believe that it can be possible to find better antigens. But of course, like in other CAR T-cell research fields, it is clear that single antigen target strategies are not the way forward. And a lot of research is now also in AML going into dual or multi-antigen targeted approaches. I've listed here all publications on dual antigen targeting approaches, but these are also using the conventional antigens as backbone. So here you see the combinations with CD33, and here you see combinations with CD123 and CLL1, and there are some other atypical combinations that are being explored or that have been explored, like NKG2D ligands with FLT3 or PDL1, and CD13 with TIM3 CARs. So a lot of work is going into this combinatorial targeting, which has the advantage that it can be a strategy to circumvent immune escape due to downregulation or loss of one of the antigens. And it can also be a strategy, especially if you do a logic gating or a more rational, if you target a rational combination of antigens, that you can have a targeting more specifically directed towards the AML cells, leukemic stem cells, while leaving the normal hematopoietic stem cells, progenitor cells alone. And the use of adapter CARs allows for such flexible targeting. So an adapter CAR or a universal CAR is actually a CAR that does not recognize a target antigen on the tumor cell surface by itself, but that has an adapter platform. So if you use an adapter molecule, for example, an adapter molecule towards CD33, this molecule will bind to CD33 on the AML surface, and on the other hand, it will bind to the docking station on the CAR on the T cell. And you can change, of course, your adapter molecules or your combination of adapter molecules, and you can also have or adapt it to the individual antigen expression profile of an individual patient. And I think this is an interesting strategy, especially in AML, where we have an heterogeneous expression of antigens and where it will be needed to actually combine different antigens and to adapt the antigens that we target to the individual antigen expression profile of the patients. So several publications on this topic already with different antigens. Apart from finding better antigens or combinations of antigens, a lot of work is also going into the CAR structure and in optimizing the design of the chimeric antigen receptor. And as we all know, a CAR is composed of different building blocks. The outer part of the CAR is the antigen binding domain, or ABD. This is usually derived from an antibody, a conventional monoclonal antibody in single-chain variable fragment format, and this will recognize the target antigen. The antigen binding domain is linked to the transmembrane domain, or TMD, by a hinge or spacer. And then intracellularly, we have the T-cell signaling domains, the co-stimulatory domains. Sometimes we add other domains. And then you have finally the fourth component, which is a CD3 zeta chain of the T-cell receptor. And each of these building blocks, we can do modifications to optimize the CAR. And for example, we can change the antigen binding domain. And a lot of research, also from my group, is going into finding alternatives for conventional monoclonal antibodies. So focus is going into nanobodies. And as we know, nanobodies are single domain antibodies. They can be derived from llamas. And these single domain nanobodies, they are smaller, they are more flexible. They can target difficult to reach antigens or epitopes. And this is an advantage to the larger conventional monoclonal antibodies. Also in other fields, like in myeloma, there's also a great deal of interest in nanobody-based CAR T-cell therapies, and this is also the same in AML. So focus is now also going on in developing nanobody-based CAR T cells. And our group is trying to immunize llamas as well as sharks with AML antigens and leukemic stem cell antigens to generate nanobody-based nanobodies and to implement these nanobodies in the design of multi-antigen targeted CARs. For the antigen binding domain, it's actually also possible to interfere with the antibody, with the scFv, so that it recognizes other epitopes. For example, for CD33, it has been shown that targeting the distal epitope is inferior to targeting the membrane proximal epitope of CD33. So efficacy is dependent on which epitope of CD33 you target. So people are altering the antigen binding domain, the antibody, so that it targets actually the membrane proximal epitope of CD33 and not the distal epitope. We can also change the hinge spacer, and one interesting concept, which was recently published by Appelbaum in Journal of Clinical Investigation, is actually to construct a dimerizing agent-regulated immunoreceptor complex. This is actually a CAR construct or a CAR that is composed of two separate components. You have the extracellular component that recognizes the antigen, in this case CD33, also the membrane proximal epitope, and also derived, the antibody is derived from a llama, so it's a nanobody-based CAR. And the other component is composed of the T-cell signaling domains and the CD3 zeta chain. And both components of the immunoreceptor complex have embedded rapamycin-regulated heterodimerizing platforms or docking stations. So if you use or give rapamycin, the two components will come together and you will have a functional CAR that will trigger T-cell activation upon CD33 recognition. If rapamycin is withdrawn, the two components come off each other and the CAR is no longer active. So this is actually a new architecture of the CAR that will help you in the case of unwanted toxicity. You will use this CAR T-cell therapeutic product together with rapamycin, and if unwanted toxicity occurs, you can actually withdraw a rapamycin. And then the CAR will no longer be functionally active because the two components come off each other. Here's another publication published in Cytotherapy where the hinge or spacer was adjusted, as well as the intracellular co-stimulatory domain. So people are not only focusing on the regular co-stimulatory domains, such as for 1BB or CD28, but also looking into other co-stimulatory domains or even combinations of co-stimulatory domains to generate third-generation CAR T cells. We can also add other stimulatory domains, T-cell stimulatory domains. For example, a recent publication in Nature Communication embedded a CJUN motif in the CAR construct so that these CAR T cells overexpress CJUN, and this transcription factor actually helps CAR T cell function and endows these CAR T cells with improved anti-leukemic activity. Finally, apart from finding better antigens or combinations, better CARs, we can also focus on the T cell, on the immune effector cell, and maybe enhance T cell function. This can be done, for example, by genetically engineering these T cells to overexpress interleukin-15. So this is actually an immunostimulatory cytokine, also drives T cell memory. And we can also do the opposite, for example, by downregulating immune inhibitory signals, such as programmed TET1, the immune checkpoint molecule. So PD-1 silenced CAR T cells are also being explored, and we are now using CRISPR technology, or other gene editing technologies are being used to silence or knock down PD-1 and to improve CAR T cell activity. Apart from using autologous T cells, we know that T cells in AML patients can be dysfunctional, can have reduced function or be exhausted. We can also use healthy donor-derived T cells, allogeneic T cells. Some publications on allogeneic CAR T cells in AML. Of course, this will need gene editing, TALEN or CRISPR, to actually knock down the endogenous TCR. But these strategies are currently also being explored. Here is a paper with TALEN-edited universal CAR T cells targeting CD123. And here's another paper that used CRISPR with a CAR T cell targeting CD33. Apart from using conventional T cells, we can also use gamma delta T cells. Here is a paper using even an allogeneic gamma delta T cell line, delta 1 T cells called. Our group is also focusing not per se on conventional T cells, but the tumor infiltrating lymphocytes, TILs, that infiltrate the bone marrow and that we believe have superior activity or might be the T cells that we need to tackle the AML cells and the leukemic stem cells. And finally, if we speak of T cells, another important immune effector cell type are NK cells. So some publications about the use of CAR NK cells in patients or in AML. Some have already been tested in the clinic in early phase clinical trials. So instead of using conventional T cells, we will be using NK cells that can be derived from different sources. Our group is currently developing a CD70 targeted CAR NK cell product for AML, which is currently in the translational phase. So we hope to embark on an early phase clinical trial in 2025 or 2026, depending on the current progress of the translational research. Some groups have used NK cells targeting CD33, even combined with CRISPR to improve NK cell function by downregulating NKG2A or disrupting the NKG2A axis. And another group has used TIM3 targeted NK cells. This was in NK92 cells, which is an allogeneic NK cell line. And even a publication has been published where these CAR NK cells, CD33 CAR NK92 cells, have been used in AML patients to treat AML patients. Finally, we can use CAR T cells separately, but we can also combine them with other anti-cancer drugs. And most notably, several publications have now been published of combining CAR T cells with hypomethylating agents, azacitidine and decitabine, which is currently one of the standard treatments used in older AML patients, patients that are not fit for intensive chemotherapy or stem cell transplantation. The combination of CAR T cell therapy with hypomethylating agents makes sense. Azacitidine, for example, and decitabine can increase expression of antigens on the AML surface, such as CD70, CD123, and it can also directly improve CAR T cell function. So this is, I think, an interesting strategy for the future, combination therapy of hypomethylating agents with CAR T cell therapy. To conclude this webinar, I think if we find better antigens or combinations, if we work on better CARs and maybe also better T cells or immune effector cells, we will be able soon to unlock the full therapeutic potential of CAR T cell therapy in AML. And with this, I would like to thank you for your attention, and I'm happy to receive some questions.
Thank you very much, Dr. Anguille, for fantastic and very comprehensive webinars. This is probably the most comprehensive webinar lecture I've ever watched and heard about CAR T cells in a very difficult context, namely AML. So we have a lot of questions, so I'll try to structure them a bit. And the philosophy of CAR T cells is more about, at least in lymphoid malignancies, a sort of a single shot treatment. Done and then wait and watch. And actually, patients usually love it because they have a treatment-free interval or they are cured. So here, it looks like we have a few questions about sequencing. So how do you see, irrespective of the target, assuming tomorrow we have a nice CAR T cell construct, effective, could be safely used, how do you see the ideal combination between induction chemo, transplant, CAR T cell? How would you put all this together?
Well, this question is about the positioning of CAR T cell therapy in AML. For me personally, I would implement CAR T cell treatments more as a sort of a myeloablative conditioning strategy. For example, in patients that are chemo refractory, you know that actually 10% of the patients are refractory to intensive chemotherapy. These patients have a very poor prognosis. So it makes sense in these patients to go for a non-chemotherapy based approach to salvage these patients. And then CAR T cell therapy comes into the fore. I think even if we are targeting CLL1 or CD33, CD123 or combination, we have these CAR T cells as a myeloablative approach, can bring the patients into a remission in a non-chemotherapy fashion. And then we can proceed to allogeneic hematopoietic stem cell transplantation as we anticipated. I also think that it will be a combination of CAR T cell therapy and hematopoietic stem cell transplantation. What we are now also witnessing is actually CAR T cell therapies used together with gene-edited hematopoietic stem cell products, where, for example, the target antigen has been knocked out of the hematopoietic stem cell product. And this is, of course, a very interesting strategy to pursue, I think. So for me personally, it will be combination, and especially combination with HSCT. It will not be an alternative for HSCT, as it will, for example, maybe be for myeloma, where currently trials are comparing CAR T cell therapy with autologous HSCT.
Thank you very much. We have another question within the same spirit of combination about combining CAR T cells with the advent of more targeted drugs in AML, anti-FLT3, gilteritinib, sorafenib, a little bit of midostaurin, anti-IDH1, IDH2, ivosidenib, and azitinib. How do you see these combinations?
Well, the literature on this topic is quite scarce. So I did a search. There are some publications on the use of FLT3 targeted CAR T cells with gilteritinib, for example, with FLT3 inhibitors, which actually shows indeed synergistic activity. So it's not only activity directed towards FLT3 itself. Combination of gilteritinib and FLT3 CAR T cells can also be synergistic, and gilteritinib can also have activity on the T cells. But for other drugs like venetoclax, which is commonly used, or other IDH1, IDH2 inhibitors, I couldn't find any literature.
Okay, thank you. So we have also questions about the source of cells for manufacturing CAR T cells, especially in the context of allogeneic stem cell transplantation. So would you consider the patient autologous own T cells? Would you consider the T cells from the donor in case of an allo transplant scenario? or you would favor the NK cells or maybe other subsets like gamma delta?
We are not actually in our center. We are not doing autologous stem cell transplantation for AML. I would rather not use an autologous product for obvious reasons. And especially for me personally, it will be T cell function that will be the main driving factor why I would go for donor-derived T cells. For me personally, I think it would be interesting to go for alternative sources, such as gamma delta T cells and even NK cells, I think are also an interesting avenue, also in AML, because NK cells also have direct anti-AML activity. We can prevent issues like graft versus host disease by using NK cells. So I think it's an interesting avenue. So for me personally, I would go for the CAR NK cells or CAR gamma delta T cells.
Excellent, thank you. So in line with this, the question is, when you use CAR T cells, for instance, in relapse AML, the question is, how confident do we need to be that we are well aware that we are targeting the most important antigen that is a fundamental part of the leukogenesis process?
That is really correct. And we all know that AML is a very heterogeneous disease. It's probably one of the most heterogeneous hematological malignancies. And to answer that question, I think there will be no one size fits all approach. So I believe it would be best if we can develop like a rapid tool to do antigen profiling of an individual patient, especially focusing also on the leukemic stem cell compartment. So single cell antigen profiling quite rapidly and adapt actually the CAR T cell approach to the individual antigenic profile. That will be the way forward.
So in line with this, actually, we have Dr. Dragani mentioning that what is your opinion about the somatic mutations and the phenotypical complexity heterogeneity of AML indeed, and maybe the type and the origin of the leukemic stem cell on the efficacy of CAR T cells?
That's a good question. I don't know whether actually the current paradigm, the risk classification that we are using with favorable, intermediate, and high risk AML and all adverse molecular and cytogenetic abnormalities also applies to CAR T cell therapy. My hope is actually that CAR T cell therapies can overcome this individual risk based on different molecular or cytogenetic abnormalities.
Okay.
But
So
it needs to be proven.
in the same line, we have Dr. Esra Gulduran asking about the AML microenvironment and whether, for instance, analyzing the microenvironment sequencing along with tumor antigen detection can be useful in designing the ideal CAR T cell construct.
It's something I didn't touch upon, but the tumor microenvironment is quite important in AML. It's hostile. So several immune cell players like myeloid-derived suppressor cells, macrophages, also mesenchymal stromal cells are known to inhibit CAR T cell function. And there are several combinatorial antigen targeting approaches that are not only targeting antigens expressed on AML cells itself, but also expressed on the other immune cells in the bone marrow microenvironment. And one example is, for example, CD146, which is expressed on AML, but also on mesenchymal stromal cells. So if you have an approach, for example, targeting CD33 and CD146, you will target not only the AML cells, but also the mesenchymal stromal cells. And the same applies, for example, with NKG2D ligands, which are also expressed on, for example, myeloid-derived suppressor cells in the bone marrow.
So
We
let's
are
move.
focusing
Yeah,
on,
sorry.
for example, CD200, which is abundantly expressed on AML and leukemic stem cells, but which also acts as an immunosuppressive molecule. So it's actually an immune checkpoint molecule like PD-1 or CTLA-4. So targeting this molecule can actually not only target the leukemic cell itself, but it can also dampen the immunosuppressive effects mediated by the AML cells on the
So
T cells.
thank you. So let's move now to the potential risk of CAR T cells, because obviously these days there are a lot of debates about T cell lymphomas induced after CAR T cells, but also some other secondary malignancies. And we have a question here from Dr. Thomas Henneke, another question from Dr. Arbab about this risk of inducing lymphoma. And in this situation, should we include a sort of a suicide gene? Is it related to the choice of the co-stimulatory domain, for instance? What are your thoughts about this? We're not yet there, because obviously, if we are talking about the future risk, it means we have succeeded already. But I think it's an important issue for the community.
Yeah, I agree. In AML, it has not yet been described. So the atypical or rare toxicities like T-cell lymphomas or Parkinsonism, which we are now seeing in BCMA-targeted CAR T-cell therapies. But of course, these trials are still early phase, and long-term follow-up is not yet available. So it's difficult to tell. And especially also because in most of these trials, the CAR T cells have been eliminated by doing a subsequent allogeneic hematopoietic stem cell transplantation. So the question is, will these cells persist for a long time? I think with the current CAR T cell therapies, persistence is very poor. And this is why I believe that these typical long-term complications that we can see in patients with lymphoma, that we will not see them with the current CAR T cell therapies that we are developing in AML.
Wonderful, thank you. So, okay, I'll take one last question, which again is about the future, but why not? I mean, let's think about the future, because the future comes soon enough, as Albert Einstein used to say. So one important question from the audience is, if we have hypothesized that generally all AML or most AML cases are preceded by SHIP, can we intervene earlier at this stage? What do you think?
That's a very good question, actually. But that will be then for the patients with more who have known SHIPs with more myelodysplasia-related abnormalities. So I don't know for the younger population whether that also applies. I don't know.
Okay, big question mark. Obviously, it's a very, very hot topic, and Dr. Anguille, you did absolutely fantastic. Did a great job. Very difficult topic. A lot of questions. I do apologize. We were not able to take all of them because we needed to structure a little bit the discussion. But I'm sure you can reach out to Dr. Anguille. And as usual, all the ICH webinars will be available on demand on the Academy website. Very easy, ich.org, guys. So please connect. You can also, using the ICH new platform, collect your CME point if you manage, of course, to successfully answer the different questions. These are the CME points delivered by EBA. So for the time being, I would like to thank again Dr. Anguille for a lovely webinar, very comprehensive review of the current available research evidence in this field. I'd like to thank you all for staying until the end, for participating. And as usual, I'll see you for sure in another future ICH activity. So for the time being, please stay safe and keep well. See you soon.